Nice one. Thanks, Tracy. Appreciate it. Evening, folks. Hope you're all doing well. Thank you so much for logging in and joining us this evening. And thanks to South Dublin County Sports Partnership for the opportunity. As Tracy said, my role is an assistant lecturer in TUDublin based in the Tallaght Campus. And a lot of my area of teaching is along the lines of kind of biochemistry, metabolic health, human nutrition, and then I teach on sports nutrition as well. Aside from that, I'm also a performance nutritionist, so I'm working mostly with kind of inter-county Gaelic football teams and previously been involved in rugby. So I suppose I have to give the caveat to the start of this talk in terms of what I'm going to talk through is basically my interpretation of the best evidence that I've come across with respect to kind of the physiology behind menopause and also some of the nutrition and training interventions that can be of benefit. Nothing I say is kind of medical, so I wouldn't take anything I say in lieu of any medical advice. You might have gotten already, so I just have to put that out there before I kick on. So what I was putting this together, I thought, what could we do in terms of what are the kind of key things that would be good to talk through and kind of understand? And if we kind of take a look at the menu, I'll start off a little bit with a brief introduction of kind of like defining what menopause is and talk about some of maybe the kind of physiology behind it, as like what's actually taking place within the body. What I'll do then is I'll move on to see, well, what do those physiological changes actually mean in terms of what are the consequences, what happens to the body? And that leads us nicely on to, well, if we understand what happens within the body, do we have any sort of dietary or nutritional considerations or things we can do from a nutrition perspective to offset those consequences? And then lastly, if we understand some of the physiology and things that's taking place during menopause or through the kind of perimenopause period, are there any sort of training modalities and exercise recommendations we can make to, again, offset some of those consequences? And at the very end, it is just quite detailed in terms of the Irish Nutrition and Dietetics Institute do have guidelines for nutrition and menopause. So what I try to do is just I'll put them in at the end, and then when the slides get sent out, you can have a look at them and kind of use them as a reference point as well. So if that's okay with everybody, I'm just going to crack on. So first of all, just to kind of put a definition on things, if we're talking about what menopause is, it's the permanent cessation of our menstrual cycles following the loss of ovarian follicular activity. And the two ways to think about it are what you typically refer to as natural menopause, or sometimes referred to as spontaneous menopause. And then the other way to think of it is what they call iatrogenic or secondary menopause. And this could be as a result of maybe there's been removal of ovaries, for example, due to surgical menopause. You could potentially also have ovarian failure, possibly as a result of things like chemotherapy or radiotherapy. But what I'm mainly going to talk about today is none of the secondary stuff. It's mostly the natural menopause or the spontaneous menopause that happens as people get older. So usually when we think of some of the consequences or the manifestations of symptoms of menopause, we probably associate it with an increased prevalence of things like obesity, metabolic syndrome, cardiovascular disease, and then osteoporosis, which is a disease relating to loss of bone. So they're the types of things I'll be talking about in terms of kind of consequences and then things we can do from a nutrition and training perspective to hopefully offset those. So just to kind of put it in perspective in terms of what essentially happens, if we take a look at the natural normal reproductive phase that would take place during, you know, normal healthy menstrual cycles, you kind of what they refer to as your pre-menopausal years. And if you look here on the kind of top right or top left of this graph, you see this GnRH. So that's just a hormone, gonadotropin releasing hormone. And where you see those black arrows, that's just kind of indicating the time within a normal menstrual cycle in which this is kind of released from the pituitary gland. So when this hormone is released, it kind of stimulates the growth and release of other hormones. So you might see there in the kind of dark red line kind of towards the middle, that FSH, that's follicle stimulating hormone. And then you have another one there, that blue line that really peaks up around day 14, that's luteinizing hormone. And these all come from the anterior pituitary gland, as I mentioned. So why these two are really important is that dark kind of red line that's kind of in the middle of everything. what that really seems to do is stimulate the release of estradiol, which is that green line. You can kind of see that peaks around day 10, drops around day 14, and then peaks again a little bit around day 20. And you'll also see inhibin B, which is a kind of pink line that kind of peaks mostly around day 14. So what these two things, the green line and the kind of pink line, they're really important because they actually provide feedback to the pituitary gland and your hypothalamus, which are just regions in our brain. And they can really modify or fine tune the production of that first hormone I mentioned at the top, the black GnRH. So in a way, the reason why I thought it kind of functions like a dimmer switch to put a tight regulation onto how much control or how much of those hormones are being secreted and when they're being secreted throughout the normal menstrual cycle. So there's an overall coordinated effort and a timed production and release of all of these different hormones. And ultimately what this does is it manifests itself in the development of the ovarian follicles. So you get ovulation and then you get menstruation. When we look through then what happens to that menstrual cycle after menopause. So after menopause, essentially the ovaries are depleted of their follicles, and the follicles are just the sacs that would contain the eggs. And if you take a look again at our different color lines, so our estradiol and our green and our inhibin B and our pink, you can see then that the production of those starts to fall. So now we've started to move out from the actual weekly cycle. We're looking over a period of years. So you'll see that the production of that estradiol and inhibin B falls, and therefore ovulation and menstruation no longer occurs. So you have the cessation of menstruation taking place. So when you have the loss of, I suppose, the ovarian responsiveness to your follicle stimulating hormone and your luteinizing hormone, essentially you've got a loss of this feedback loop. So the dimmer switch doesn't seem to work anymore. And you'd overall get a change in what hormones are produced and how much hormones are produced. So you get an increased production of that GnRH, that black one from the last graph. You'll get an increase in your FSH, your follicle stimulating hormone, that dark red line, and an increase in the production of your luteinizing hormone. And one of the key characteristics of postmenopause is the fact that you'll see increased levels of that dark red line towards the top, follicle stimulating hormone. So what this diagram tries to show essentially is a kind of where these things take place in the body. So as you can see kind of towards the center, and I've highlighted in the red box that GnRH hormone, that's stimulated or produced in the hypothalamus. That will then send signals down to the pituitary gland for your luteinizing hormone and your fractional follicle stimulating hormone, excuse me. So what happens is with the kind of pulsatile release of that GnRH, we get the regulation and the release of the luteinizing hormone and the fractional stimulating hormone. And essentially what happens is these are all going to play a role in kind of controlling the development of the ovarian follicles, development of kind of the process of ovulation, and therefore menstruation. If you kind of take a look more towards the right-hand side here, you can see hypothalamic aging. As a result of kind of aging, we get a decreased or desynchronized secretion of that GnRH hormone. So you get an impaired timing of your luteinized hormones surge. And what this has a downstream knock-on effects is changes in your estradiol fluctuation and decline. Ultimately, what happens is you're going to end up with a reduced production of estrogen over time. In 2012, there was a publication of what they call the STRAW classification, and the STRAW stands for the staging of reproductive aging in women, or the staging of reproductive aging workshop. And what they tried to do was separate women's life into 7 key segments, which range from your onset of your menstrual cycles at the kind of menarche, as you can see towards the left-hand side of the green arrow, early -5. And then you've got the reproductive age all the way up to what we call the perimenopausal and then the postmenopausal phases. The menstrual cycle, or the kind of principal descriptive criteria, are kind of highlighted in the kind of green boxes towards the top. They're kind of like the descriptive type of things. And then in the kind of yellow boxes, you've got your kind of biochemical or possibly your imaging or supportive criteria that would kind of classify each of those phases. And then in the blue boxes, you can start to see some of the symptoms which might manifest as you go through the different stages. So when we look there in the purple box that I've tried to highlight, these are stages -1 -2, -1, and 0. And what they really are there for is they kind of categorize what we call the early menopausal transition into the late menopausal transition, and then you've got the final menstrual period in that kind of order. So that point 0, that FMP, would stand for your final menstrual period. And a lot of the research seems to kind of base its findings around distance from whether it was before or after that FMP, that final menstrual period point. So what they'll do is they'll use an individual's age at natural menopause, and they'll try and do that to indicate the timing of menopause. And then they'll confirm that after 1 year of amenorrhea, which is the loss of a period. During the early stages, your estrogen levels are likely going to be fluctuating, but there's probably going to be enough estrogen there overall, and the cycles are usually somewhat ovulatory. If the estrogen levels start to drop, they probably aren't going to be maintained for a good level for very long, or not even maintained at a low level for very long, and they'll typically fluctuate even further after menopause. And symptoms are generally quite mild in these stages. Most women will likely notice them, but at this kind of early stage, they don't necessarily require treatment. The reason why we mention estrogen is it seems to be a key player in the knock-on effects in terms of what are the metabolic consequences as progressing through menopause. So while you might not experience significant symptoms, the fall of estrogen does result in changes throughout the body. And the key things to be aware of from my perspective, nutrition and training, will be things like bone loss. There can be a tendency to see an increase in abdominal fat or visceral fat around the kind of abdomen there. And you could also end up, and you will likely see, an adverse cardiovascular risk profile. So most people associate estrogen with its effects on the female reproductive system, which it does. And in addition to that, even in men and women, it's involved in the supplying of calcium to our bones. It helps with maintenance of the health of our blood vessels walls. It can help play a role in regulating blood cholesterol and our triglyceride levels. And it can also help with maintenance of the elasticity of the skin. So therefore, if you have a reduction in estrogen as a result of menopause, that's going to have knock-on effects on your metabolic processes. And these knock-on effects likely manifest as bone loss, a change in our blood lipid profile, so changes in cholesterol or triacylglycerol concentrations, and therefore they will have a knock-on effect on your influence on your cardiovascular risk. And you could also see changes in the deposition of adipose tissue or fat around the abdomen for the most part. So what I thought I'd do is I'd take each one of those and look a little bit of research into those areas: bone loss, adverse cardiovascular risk profile, and abdominal fat, see what some of the research says, and then maybe we can look at it from a nutrition and training perspective to see is there anything we can do to kind of help or offset that. So the first place I'll start is going to be bone loss. So as both men and women age, you can see, if we start on kind of the bottom left here, the kind of greatest portion or period for bone growth is going to be during kind of childhood and adolescent development, with most adults, females, reaching peak bone mass around age 30, and then males kind of reach it a little bit later towards kind of the mid 30s. And what's nice about this is our bone is quite responsive to kind of the stressors of the environment. So it can be modified in response to physiological influences such as circulating hormones. It can also be influenced by mechanical forces such as the stress placed on it by muscles pulling on it as a result of training. So there's an ongoing process of this bone remodeling whereby some cells are breaking down our bone and other cells are working to rebuild our bone. And essentially, it's going to be a turnover of the main minerals in bone, which are calcium and phosphorus. And we're trying to maintain those levels at an equal keel over the course of the life. At around kind of age 30 or 40, you kind of hit your peak and start to drop off. And what happens there is that the cells that break down bone start to kind of outwork the cells that rebuild bone. And then, as you can kind of see highlighted in the blue box here, there seems to be an exacerbation or an increased rate of bone loss due to menopause in females, which kind of places them at a kind of a worse disposition. So what this essentially could mean is your risk of developing things like osteopenia, which is a low bone mineral density, and osteoporosis, which is kind of weak or porous bones, that could potentially leave you susceptible to an increased risk of fracture. And some of the potentially things we could do is try to achieve a higher peak bone mass a little bit earlier on in life. So getting exposed to kind of training and bone growth stimulatory effects earlier on. How this kind of all works is, if you take kind of the normal kind of process of aging on the left here, some of the things that we typically see that could manifest as osteoporosis or osteopenia is a vitamin D deficiency. Maybe there's a decline in calcium absorption, or maybe there's no real synthesis of vitamin D. Or you could see, as a result of a lack of physical activity, so the kind of muscles aren't pulling on the bones to kind of get them to respond to mechanical tension. And there could also be sarcopenia, which is kind of a loss of muscle tone or activity as a result of inactivity. And what essentially means is there's not enough stimulation for the cells that kind of grow bone or maintain bone to stay active, and they kind of get outpaced by the cells that break down bone. And essentially you get a reduction in bone formation and maintenance of bone breakdown, for want of a better word. And what this means is you could get leading to low bone mass and a loss then of your kind of bone architecture, which could manifest as fractures. Over towards the right hand side is the way this is exacerbated is because of the estrogen decline we mentioned that takes place during the menopausal period. You get an increase in this osteoblasts. They're the cells that break bone down. Essentially, you get an increase in them, or you get a conversion into those cells that break down bone, and that kind of just speeds up the process and exacerbates it. So you basically have a reduction in your estrogen production. It results in an increase in the activity of the cells whose job it is to break bone down. And what that ultimately means is more bone is broken down than is built up, which leads to an overall decrease in your bone mineral contents. That's going to weaken bones and making them more susceptible to fracture. And these changes are going to be further compounded by your general age-related changes in bone metabolism and bone remodeling, likely things like a change in your vitamin D and your calcium levels, maybe things like secondary hyperthyroidism, and likely less mechanical stimulation of the bone turnover as a result of physical inactivity. So just another way to look at that is if we have what's called bone modeling, where your kind of mature bone tissue is removed from the skeleton, and then you've got bone formation where we can kind of try and replace that bone. And ideally you have a scenario up the top here where a healthy bone looks like these cells, these yellow osteoclasts, which are there to clear out some of the kind of old bone, are matched by these osteoblasts, which are there to kind of replace that bone and rebuild it. So overall you end up with a balance between build up and breakdown. What happens in kind of osteoporosis and age-related diseases and is exacerbated by menopause is you now have a situation where your cells that break down the bone are kind of overtaking, or there's more of them compared to the cells that build up bone. And over enough time, what can happen is weakening of the reduction in the mineral content, weakening of the structures, and then you get a susceptibility to what they call an osteoporotic fracture. The unfortunate thing about all this is bone loss is extremely gradual and it's painless, so there's no real symptoms. The only time you can really see if there's any sort of only time you can see it is when it kind of gets to a stage where it's too late, where you might see an obvious sign of a fracture, you might see back pain, you might see a loss of height, and you might see people with the development of that Dowager's hump or that kind of curve in their spine. So for anyone that's kind of concerned or potentially concerned, the way they will typically measure this in a clinical setting is through a DEXA scan. And as you can see on the screen here, it's able to shine X-rays and kind of quantify the amount of bone mineral content, and you're able to get I think it's a T-score or a Z-score they call it, and you can compare yourself to the kind of population norms and things like that. So that's one of the ways we can view it potentially in the clinic if you need it long before things get to a point where it's too late. Some things with respect to, I suppose, changes in bone morphology we can, and other things we can't unfortunately influence. So the things on the left are fixed risk factors. So we're all getting older. Unfortunately, females are more susceptible to osteoporotic fractures due to the fact of going through menopause. And as you see here, I've highlighted menopause as one of the kind of fixed factors that kind of will also impact on that, and other things like glucocorticoid therapy or rheumatoid arthritis or things like that. What is somewhat of a a nice thing is there are modifiable risk factors, and the modifiable risk factors are the things I'm hopefully going to try and talk you through this evening. So things like your body mass index, too high or too low, potentially poor nutrition, if there's a vitamin D deficiency, if there's a lack of physical activity or insufficient exercise, if there's low dietary calcium. And then one of the things we can look at is how we can train to prevent falling, which, falling on impact on weakened bones could be a reason why people start to see fractures. So if you can reduce those, we'll be doing pretty well. So then when it comes to, I suppose, training or goals of some sort of osteoporotic prevention program, some of the main targets for any sort of training intervention or possibly dietary intervention, we're going to try and optimize people's peak bone mass. And we can do this through a combination of physical activity and nutrition interventions. Secondly, then we're going to try and reduce bone loss with aging, and especially during menopause. And likely that's going to be through physical activity, possibly through some nutrition. And then ultimately we want to reduce the risk of falls. And that's going to be through like strengthening, proprioception, balance exercise, looking at people's environments, and then potentially looking at if they need any medications. But again, like I said, that's more of a clinical thing and something I'm not necessarily qualified to speak on. The next key area of kind of metabolic consequences is this idea of the change in your cardiovascular risk profile. So the previous slide with this similar diagram was based on what happens to bone. This one's more so directed towards what happens to your cardiovascular system. So when you have your kind of menopausal estrogen decline, you can have indirect effects on things like what they call visceral adiposity, which is the amount of fat tissue stored centrally around your organs, dyslipidemia, which is a change in your lipid profile. And what I mean by that is a change in your cholesterol in your blood. So a change in your low density lipoprotein, your LDLs, and a change in your HDLs. You could have an increase in triglycerides or triacylglycerols, potentially insulin resistance, an increase in blood pressure, and some chronic inflammation. The kind of endpoint or the manifestation of this usually starts to appear in what's known as atherosclerosis, which is a narrowing of some of the arteries and vessels. And when we have a narrowing of some of our arteries and vessels, there's an increased risk of heart disease and stroke. The other things on the left-hand side, your menopause and aging linked to kind of atherosclerosis, or a step back link, is people that are physically inactive or maybe consuming the wrong types of foods or foods in excess, as well as low physical activity, kind of reducing muscle activity, could lead to obesity. And obesity is linked to atherosclerosis development, and therefore it's linked to ischemic heart disease and potentially strokes. So this all comes from that decline or that loss of estrogen, which takes place during menopause. So I tried to get some recent data that's kind of close to home, and what I came across is this Healthy Ireland survey report, and this is the 2019 version, where they actually looked at different health conditions between males and females. And as you might be able to see there, highlighted in the yellow box. So sorry, on the top row is the change in blood pressure, and on the bottom row is the kind of prevalence of health conditions, so high cholesterol. So soon after menopause, so as I scroll across, you've got ages kind of 45 all the way up to kind of ages 75 plus, and the pink dots are females. Soon after menopause, you start to see that women are exhibiting increases in blood pressure, and you're also starting to see a link to that is changes or increases in what they call subclinical vascular disease. And they'll measure that by looking at carotid and femoral artery intermediate thickness, so the kind of thickness of the vessel. And then you can also see on the bottom row there, you've got an increase in change in cholesterol levels as well, which are two of the things I spoke about on the previous slide. So what the clinical consequences of this are, they usually occur later in women compared to men, but unfortunately, the risk of stroke doubles during the first decade following menopause. And usually what happens is females are more likely to experience a stroke at an older age compared to men as a result of having gone through menopause. And when you're in early menopause and primary ovarian insufficiency, they're consistently associated with an increased risk of coronary heart disease, stroke, and mortality, unfortunately. And then if we take a look at your increased risk of abdominal fat, so like I mentioned, your estrogen primarily involved in the health of blood vessel walls, blood cholesterol and triglyceride levels. And these blood cholesterols and triglycerides, they're the fat particles, which essentially it's how fat is transported around in the bloodstream, essentially. So what some of the larger analyses have looked at is changes in female fat mass, and also changes in their lean mass, so kind of a proxy for your muscle mass essentially during this menopausal transition. So this is actually quite a nice paper where they looked at DEXA scans to assess body composition. So they were able to look at bone mineral content as well, but I haven't included it here. But if you can see the bottom axis, the ones going from kind of left to right, in the top left box, you've got your fat mass. And as you can see, your number of years prior to and after that FMP, that final menstrual period, which I mentioned earlier on, as you kind of get closer to that zero mark, that kind of cutoff, you can see that fat mass really starts to ramp up and increase. And it's the same when you kind of normalize it compared to body mass across participants. And if you look on the bottom two, left and right, these are lean mass, which is that proxy for muscle mass essentially. So what typically happens is you see an increase in fat and a little bit of an increase in lean mass prior towards that menstrual transition, that zero mark. And then at the start of the menstrual transition, the rate of fat gain actually doubles and the lean mass actually declines. And those gains and losses still continue for around 2 years after the final menstrual period. And then after that, the kind of trajectories of your fat and lean mass started to kind of decelerate and slow down a little bit. You can see then that the weight kind of climbs linearly during the premenopause period, and it doesn't seem to get accelerated during the menopausal transition. And then it kind of plateaus and flattens out in the years after the final menstrual period. So the issues with these changes are they're associated with an increased risk of coronary heart disease, and that will potentially compromise women's health overall on the whole. And again, if we take it back a little closer to home, so this is more recent data I was able to get from the Healthy Ireland survey from the 2022 report. And the results of this wave of the study show that 41% of the population are reporting that they're at normal weight, 35% of the population are reporting that they're overweight, and 21% of the population are reporting that they're obese. They're only slightly different in terms of their changes from the previous version in 2019. And I suppose if we look across the normal weight range is the green. As you get kind of closer to 45 to 54, 55 to 64, 65 to 74, normal weight is decreasing, and unfortunately overweight is increasing, and obesity levels are actually increasing as well. So there seems to be this growing gap across a lot of the life course in terms of both men and women who start to become overweight. In kind of the early ages of kind of between 15 and 24, roughly the same population of men and women report kind of normal weight. So it's like 64% for men and 63% for women. However, this gap really starts to widen as groups get older. And there seems to be a big gap between, I think it's men reporting to be 22% at a normal rate, and then females reporting to 64% at a normal rate. So some of the kind of thought process behind this was, well, there's likely a link between what's happening during menopause and the depositions of fat. One of the papers I came across in this area seems to suggest that while menopause does predispose you to certain risks, it actually seems to be heavily linked to physical activity levels. So what this paper was kind of culminating in or concluding is it's actually sedentariness rather than menopause is associated with a twofold risk of overweight or obesity. So this was like a population-based study they did in, I think it was Brazil, and they showed it was the people that were less active were more likely to have these risks of overweight and be obese. So what this tells me is that our nutritional intervention can be of benefit, but it's more likely a physical activity intervention is going to be of massive benefit for helping with, I suppose, offsetting gains in excess weight or reduction in metabolic and cardiovascular risk. And then one of the key things from a paper was that if we're looking at the healthcare of menopausal women, we can emphasize an overall lifestyle assessment. And two of the key components of lifestyle are going to be nutrition and physical activity levels, in combination with maybe some more kind of, I suppose, professional counseling. And hopefully then we're able to counterbalance the negative effects of the estrogen deficiency, and therefore we can counteract or potentially slow down or minimize the risk of metabolic syndrome, osteoporosis, bone fractures, and vascular events. So there's kind of the, I suppose, the doom and gloom. Apologies. What I'll do now is I'll move on to like the dietary considerations. And among the various aspects of health promotion and lifestyle adaptation throughout the menopausal period, nutritional habits are going to be one of the key players. The reasons I say that is nutritional habits, well, anyone can do them because most people, everyone eats, so they can concern all women. We can modify our nutritional intakes as needed. They can impact both the longevity and the quality of life. And then we just need to have a discussion about, well, what can we actually do? So when it comes to overall nutrition, the way I think about things is through this kind of pyramid of priorities of importance. And the key thing for me is, how likely is the diet going to be that someone can sustain it and adhere to it? So there needs to be some sort of structure in place that the individual that's of concern can stick to, I suppose, the plan, for want of a better word. The next step up is assessing a people's calorie balance or their overall energy intake and how that compares to their energy output. And then the next step up is looking at exercise. So straight away, we've got three massive players kind of propping up our pyramid. And then as you go up higher and higher, it kind of becomes less and less important, but still things you can think about. And unfortunately, from my perspective, and traditionally when people kind of hear what I do, they ask me straight away about supplements, and they kind of overlook, you know, how easy they find their diet to stick to, or what exercise they're doing, or how many calories they need to eat about that. So the kind of place I'll start is in calorie balance, and I might touch on sustainability and adherence as we go on a little later. So when I'm talking about this, what I'm essentially talking about is the energy that comes in through all the food and drink that someone consumes, and how that matches up or compares to all of the food and drink that get used up by the body, or how all the calories get expended by the body through, you know, activities of daily living, exercise, digestion of food, things like that. There's kind of two ways you can kind of tip the scale. You can have what's called a positive energy balance, whereby more calories are coming in compared to going out. And ultimately, over time, this will likely manifest and result in weight gain, and likely manifest as an increase in adipose tissue or body fat storage. Weight gain is one of the most obvious consequences, but your health of your kind of overall health and your cellular fitness can also suffer too, like that atherosclerosis, changes in blood pressure, changes in cholesterol as well, and potentially insulin resistance. On the other side of things, you could have what's called a negative energy balance, or hypocaloric. And what this essentially means is there's more calories leaving the body than there are coming in. And the two ways that you could possibly go about this is you could decide to eat less food and take in less calories on the whole, or you can continue eating the same amount of food you are eating and increase your physical activity level to increase the amount of calories that are going out. For most people, it's probably going to be a combination of two that will see the benefit in terms of overall health, body mass loss, and things like that. So what we're trying to do with our nutrition essentially is control this. We don't necessarily want to have swings in either direction, where we're kind of gaining a lot of weight one day and losing a lot of weight other days, or we're gaining lots of weights over long periods of time and losing lots of weight for prolonged periods of time, or we're not being too aggressive on one side or the other. So we're just trying to get to a point where we're, you know, in balance. We've enough coming in to match what we're doing going out. And if we find ourselves in a place where we've got more coming in, do we decide to reduce that, or do we decide to put a bit more out by doing a little bit more physical activity? The key thing with kind of furnishing those calories, if you want for a better word, or kind of the budget, if you want to think about it, is we try and fill that with as many nutrient dense foods as possible throughout the day. So when I'm talking about nutrient dense foods, I'm talking about foods that provide a lot of nutrients, so like your vitamins, your minerals, your fiber, relative to, you know, as few calories as possible, ideally. So we're talking about things like fruits or vegetables, whole grain cereals, whole grain breads, kind of lower fat or non-fat dairy, kind of leaner fish and seafood, maybe unprocessed leaner cuts of meat, poultry, nuts and legumes and things like that. this has a link between what we call energy or calorie density. And what we're talking about there is kind of the ratio of calories, which are just units of energy compared to the actual weight of a food. So, for example, if you had something that has a high calorie density, it would contain a lot of calories per 100 grams, as opposed to a low calorie or low energy density food or diet that would contain fewer calories per 100 grams. So if you think about the types of foods, and I like this because it's a visual representation in terms of the types of foods that are going to fill you up without necessarily overdoing it or providing too many calories. And if you look towards the right hand side, you're looking at mostly your minimally processed foods like your fruit and vegetables, which contain a lot of water, a lot of fiber, and then your leaner cuts of meats and fish. As you kind of move then more towards the left, you're getting more in towards your kind of higher fat type foods. So your oils, your cheeses, your nuts and butter, and likely some of your kind of processed foods will fit into that category as well. So if we can think about foods that are going to fill us up for the fewest amount of calories, that's kind of, you're on the right track in terms of getting onto a winner there. What seems to be apparent in the research is if we have a combination of nutrient dense and calorie density, we try and improve and promote fat loss if we have a high nutrient dense diet compared to a low calorie dense diet. So what we're looking at is foods on the left, so your kind of whole grains, fruits, lean cuts of meat, and avoiding some of the kind of processed and kind of foods that would have more calories per 100 grams than others, for example. So the reason why this is beneficial is it's really beneficial for actually helping us control our energy intake or our calorie intake. It's going to provide longer periods of what they call satiation, or that feeling of fullness or maybe satisfaction. It also makes meals really hard to overeat because you actually see, well, there's a lot of food here. And you also therefore get a higher total nutrient intake over the course of your day, and you get more essential nutrients per volume of food, essentially. So some of the kind of evidence to kind of support this is a nice paper from the late 1990s. And what this group basically did was they had what they call a low energy density eating plan. And what they did was they tried to assess people's overall calorie intake and its effects on weight loss. So what they have is, as you can see, you've got low, medium, and high. So this is low energy density, meaning provided very few calories per 100 grams of a food. Medium, halfway between. High, which would provide a lot of calories per 100 grams of food. So the ladies in this study ate a similar amount in terms of the volume of food, and they also ate a very similar weight of the food. But the group that were put on the lowest energy density condition, because they were able to kind of be clever in their food substitutions, they actually consumed 30% less calories than the higher energy density diet. And the key thing here was that the women in the study didn't report any differences in their hunger or their fullness ratings, and they didn't report any change in how much they enjoyed the food. So to me, this says a lot in terms of they didn't feel hungry, so they were more likely to kind of stay on track. They didn't feel like they were lacking in anything, and they felt kind of satisfied by the meals they were being provided. And they also consumed less energy overall. So this to me kind of looks like a winning strategy. And then there's another nice paper from a similar group. And what they basically did was they had a very similar type of approach where they had kind of a 2-day trial repeated 4 times. And what they tried to do was manipulate either the ladies' portion sizes in the meals they gave them, the energy density, so how many calories per 100 grams, or a combination of both. And what they essentially did was swap out some of, say, the carbohydrates like the potatoes and the rices and pastas in some of the dishes for more vegetables. And they did things like where it had in the high energy density diet full fat milk, they would have swapped that for low fat milk, or full fat yogurt for low fat yogurt, for example. And what happened was when they reduced the portion size by 25%, they saw that there was actually a 10% decrease in overall calorie intake or energy intake. But then what they saw a step further was when they reduced the energy density. So if they kept the kind of weight and the volume of food the same, but changed things like calorie content in terms of full fat for low fat, they actually saw a 24% decrease in overall calorie intake. So again, there was no kind of difference in terms of satisfaction between the different diets and things like that. And usually what seems to happen, and in practice what seems to happen, is you're able to eat quite a large amount of food, but also you're just being clever in your swaps to kind of reduce the overall calorie content of those foods. So this kind of leads to this kind of summary piece. Then if we're looking at, I suppose, a low energy density diet, is we're getting as many kind of colors on our plate. So it's high in whole fruits, lots of vegetables and grains. And also we're going to look at more so low fat dairy, things like legumes and beans, because of their high fiber content to keep us full. And then your lean meats. Overall, the diet tends to be kind of lower in fat and reduces or eliminates energy dense beverages. So probably things like cans of Coke or Monster Energy, or possibly even alcohol as well. So this idea of that you've got a high fiber, high water, low fat diet means the individual could consume an overall greater amount or volume of food for an overall lower energetic cost and still feel full. And it just makes things a lot easier to kind of stick to. And then one of the other key things to highlight is that what happens as we age is our sensitivity to protein seems to decrease. And what can happen is, as people get older, they need to likely increase their protein intake. So what I came across was the recommendation for kind of reducing frailty risk is if you have your 1.2 times your body weight in terms of protein, so 1.2 grams per kg. So the example down the bottom is if you're 60 kg, multiply your body by 1.2, and that gives you a total amount of 72 grams of protein per day. And there also seems to be evidence to suggest that slightly higher, so 1.6 grams per kilogram body weight per day, seems to be associated with greater maintenance of skeletal muscle mass. So there is a benefit to having increased protein in the diet as well, which you can likely get from kind of moving towards that low energy dense diet I mentioned previously. When it comes to, I suppose, the specific nutrition considerations for bone health, a lot of the research focuses in on your calcium intake and then your vitamin D intake, because they have a direct influence on your bone mineral density and the prevention of your osteoporosis and fracture in older adults. So the recommended intakes for calcium at the moment, I think, are 700 milligrams per day in the UK. They're slightly higher in the US. So they can be as high as 1200 milligrams. It just depends on what country's guidelines you're following. So in reality, a lot of the research was kind of suggest an intake of 1000 to 1200, so 1 to 1.2 grams of calcium per day. And I kind of think if you're kind of, kind of a bit of a plan and you're kind of strategic about it, it's quite easy to get that in over the course of a day, if not the course of a week, because we just need to look at, can we include our milks, our cheeses, possibly low fat, as we've seen, canned fish, so like sardines and salmon, because of the actual calcium contained in the bones. Some fruits can be quite rich in calcium, like your oranges, your apricots, and your figs. And then certain nuts, so like Brazil nuts and almonds are really good sources of calcium as well. And then you've got your dark green leafy vegetables like your broccolis, your kales, your bok or pak choy, depending on how you like to pronounce it. Most people probably think of your dairy products, and it's true, they're very high in calcium. You could have possibly some juices or breakfast foods, or possibly even soy milk or cereals. They might, and even breads now, could even be fortified or have additional calcium in them as well. So that would all go towards your calcium intake. To be aware of. If someone's not sure, what I came across is the Osteoporosis Foundation actually have a calcium calculator that, again, if you get the slides, if you click the link, you'll be brought to that, and put in your age, your male or female, and then you can put in how much of each food you eat throughout the day, and it's able to tell you if you're on track with hitting your calcium goals or hitting your calcium targets. And then the other key nutrient of interest is vitamin D3. It's sometimes referred to the sunshine vitamin. So it's important for our bodies. There's a couple of reasons. The first reason I'll highlight is it actually helps our intestines to absorb calcium. And this is really beneficial. If you're able to pair the supplement or pair the intake of calcium with vitamin D, you get an increased intestinal absorption. What this does is ultimately in the body helps keep our bones healthy, because if we have more calcium available, and calcium is kind of the main mineral in bone, we're able to influence that. You're also able to help regulate one of your hormones known as insulin, which helps our cells basically get the energy they need from your carbohydrates. And another thing vitamin D does is also help support our immune system. So the way it works is essentially sunlight is probably the primary source of vitamin D. We have cells on the top layer of our skin. They have this provitamin D compound. What the sunlight does essentially is hits this compound, converts it into a pre-vitamin D, and then that pre-vitamin D is converted into the active form of vitamin D3. So this reaction essentially is the main source of vitamin D throughout our lives. Unfortunately, not a lot of foods are very vitamin D heavy. A lot of the times you're looking at fortified foods or enriched foods, or possibly even supplements. So I was able to come across some of the types of foods. So the top 10 high vitamin D foods would be things like oily fish or salmon, which kind of also kind of feeds in towards our calcium needs. Certain types of mushrooms, fortified milk substitutes like soy milk, for example, tofu, yogurts, some cereals, juices, things like that. The main way to try and achieve your vitamin D intake should be through sunlight. And this kind of could potentially link into your physical activity, which I'll speak about. Is if you need to do physical activity, could you do it outside for 20 minutes and therefore get your vitamin D requirements? If possible, choose foods first over supplements to get your vitamin D when possible. And if it's just not an option, there's always a supplement. And I think the recommended intakes for vitamin D supplementation is somewhere in the region of 400 to 800 IUs per day. There's two types. The type you should probably aim for is vitamin D3, which seems to be the more active of the two. So when I'm dealing with clients and I'm talking through nutrition requirements, I always try and think of the different goals and different scenarios they might need to kind of, or might find themselves in, and see, are there any foods or what foods essentially tick as many boxes as possible for them. So what I was thinking through for this is like, okay, what types of foods could we have that are nutrient dense, high in fiber, protein rich, have calcium, and have vitamin D3? And if you're able to go through your kind of day or your week and you're regularly ticking a lot of those boxes with a lot of your foods, you're probably like 80 to 90% there of the way there. So our nutrient dense foods, like I said, are going to be your minimally processed foods, your fruits, fresh fruits, vegetables, whole grain breads, whole grain cereals. Maybe there's some that are fortified with calcium. Maybe you're putting milk on your cereal or milk into your whole grain oats, or into your oats. Maybe you're able to get outside for 20 minutes, get some vitamin D, or maybe you've got some fortified foods with vitamin D in them. That's the way I'd kind of be thinking about it. If I can tick those boxes throughout the day, multiple times per day, I'm likely 80 to 90% there. And then the last kind of section is to kind of focus on our physical activity and our exercise. And there's kind of one of the kind of quotes from one of the papers I came across was that women that are going through midlife should try and maintain or achieve normal body weight, be physically active, adopt a healthy diet, limit alcohol consumption, and not smoke. So I've already spoke about the diet, so I'll try and speak a little bit about physical activity. So again, data from the Healthy Ireland survey, again, this is 2019. And if you look just on the left, you've got 46% of all adults are hitting the national guidelines for physical activity. So less than half. And the more concerning side of that is, as you dig deeper into the difference between males and females, is women, only around 38% of women in Ireland are hitting the national guidelines for physical activity. So this was a survey sent out, and people were asked to respond like over the last 7 days, how active they've been in terms of any kind of activity they did for work, housework, gardening, traveling, spare time for recreation, exercise, playing sports and things like that. So the national guidelines are around 150 minutes of activity per week. Only 38% of women are actually hitting those guidelines. And then what's more interesting is, as you move to the right-hand side there in the dark blue, as you look at your age groups, around 2/3 or 61% of persons aged 15 to 24, they are meeting the minimum guidelines. But unfortunately, as the ages start to creep up, this declines steadily across the life course. So much so that as you get to kind of 55, 64, only 35% or 30% of females, 65 to 74, 33% or 26% of females, and then 75% plus 18% or 16% of females. The reason why we would try and encourage physical activity is, as we spoke about, it can maintain our muscle mass, and which can also maintain our balance, our overall strength. And what this is beneficial for is it reduces the risks of falling and therefore reduces the risk of fractures. There's a slight variation in terms of the type of training you need to do for, I suppose, your cardiovascular and your muscle responses, as well as the type of training you need to do for impacting your bone density, which I'll try and speak about as well. So the first thing is, like, one of the things that happens with going through kind of menopause is that change in that triacylglycerol or blood lipid profiles. And the way they measure that is to look at what are called triacylglycerols in the bloodstream. And this graph, the top one, basically shows that even after one bout of exercise, the 6 female participants in this study were able to see a decrease in their circulating levels of triacylglycerol. So one exercise session on, say, Monday had a benefit on the Tuesday. The other nice thing about this paper is they did a combination of exercise plus that energy restriction, calorie restriction we spoke about earlier. And that also seemed to have the same benefit. So there's kind of 2 ways to look at it. Is if you kind of get your calories in line, you can see a benefit. If you do exercise, you can get a benefit. If you do both, you get a benefit. I suppose one of the kind of caveats to this is that the paper actually did a 90-minute exercise session. And I know a lot of people are probably being a bit like, okay, well, where am I meant to get 90 minutes in my day to do physical activity? There does appear to be evidence to suggest that you can break your physical activity up over the course of the day and still see similar, or if not the same, benefits. So you don't necessarily need to worry about, I need to block off 60 or 90 minutes here to, go for a walk or go for a run or cycle. It could be a case of, I can squeeze 20 minutes here in my morning. I might get 15 minutes at lunch, and I could get 40 minutes in the afternoon if I wanted to do 3. If not, I could do an hour tomorrow. And once you're kind of hitting the overall weekly targets, you seem to be in a very beneficial and positive place. So some of the different modalities, and this is kind of aerobic training that's more cardiovascular focused to help with cardiovascular system. If we're looking at aerobic activities, we're utilizing a lot of large muscle groups, keeping our heart rate up. That's quite a good thing. And I suppose the options for cardiovascular activity are kind of limitless, and kind of you can use your imagination as much as you want. So you could have things like walking, jogging, biking, swimming. These are all kind of the traditional things people think when you think cardio. It doesn't have to be overly taxing or extremely hard. You could do some modality that you find entertaining or fun, for example. Maybe people don't want to go to the gym and run on a treadmill. Maybe people don't want to go out walking when it's cold and dark. Maybe there's an exercise class you could sign up for. Maybe there's something like dance or Zumba or something. And then even things for people that maybe they don't think exercise is their thing. There is evidence to suggest even doing like some sort of moderate things like around the house, like housework or gardening, for example, that would contribute towards your daily physical activity as well. So that can be of benefit. The kind of key thing would be to kind of start where you are, start light and kind of build your way up. Don't try and throw yourself into anything too excessive too early on. The next thing is strength training. And the reason why this is important is because your osteoporosis risk does kind of increase during menopause. Strength training is going to be really vital to help offset that. So what happens is through some strength training, you can help kind of stimulate bone and muscle strength. You will likely get a benefit in terms of possibly some calorie expenditure, and you could get a kind of maintenance of metabolic rate. There's a whole spectrum of options here. Like some people might feel like, okay, joining a gym is for me and I can join a gym and use the weights there. Might not be for everybody. Is there a couple of weights you could get, like kettlebells or dumbbells at home and do things like that? And even if you're not sure that you want to start with body weight, you could get these little resistance bands. And the main goal is you're taxing your muscles and you're putting strain on your muscles and putting strain on your bones to kind of get them to adapt. And you're just trying to offset any potential losses in muscle mass or bone mineral content. It changes slightly when we're kind of focusing our training to train for bone health. Your best benefit here, best bang for your buck, is going to be some combination of both strength exercises. So maybe it's dumbbells, maybe it's kettlebells, maybe it's resistance bands, maybe it's kind of push-ups, or maybe it's squats to a chair at home, and some form of what they call impact exercise. So impact exercise is like, the reference they use in papers is jumping, but I'm very aware that not everyone wants to jump or is capable of jumping. So you could think of slightly higher intensity activities where you're moving kind of rapidly and you're kind of putting force on the floor. So this is where I think things like dance classes are really beneficial, because there's a kind of a step required and you're planting the foot, and that can have beneficial effects on bone content in the feet. So you could try and incorporate exercise types that get all of these together in one session. So again, that kind of bang for your buck, box ticking. Can I train strength, bone health at the same time? Most likely, yes, you can. And there is also evidence to suggest that there's like racket sports where you actually have the involvement of striking something, that actually places strain on the bones in the forearm and wrist that can actually, you know, if built up gradually, can actually benefit the bone mineral content of those bones as well. I also know that South Dublin County Sports have a whole different variety of classes that offer things from walking, orienteering clubs, running clubs, as well as different classes like modified circuit training for different age groups and things like that. So there is a lot of variety and there's a lot of options, and you don't feel like you have to kind of get sucked into one way of training only, for example. And then just to kind of set things up, set the scene, is just what I find really helps a lot of clients is if they're able to set goals and set themselves targets. And once they're able to set targets, they need to be a little bit realistic. You know, saying I'm going to now go from doing nothing to cycle the Tour de France, or, you know, run a marathon next year or this year, might be not overly realistic. It's nice to have those longer term goals, but if you can do that and then break it down into, okay, by, you know, summertime I'd like to be able to get out for a 40-minute walk and not lose my breath or something like that. Make sure it's attainable, because you want to make sure it's like just out of reach, that you're motivated to still go for it, but not so far out of reach that you lose all hope and lose all motivation. And just be really specific. A lot of the time people say, I want to exercise more, and if you can drill down into that statement a little bit and say, well, what does that look like? What exercise do you want to do? When are you going to do it? How long are you going to do it for? And then maybe, is there someone you want to do it with, or someone you can take with you to a class or go for a walk with? You know, a spouse, partner, workout partner, friend. I even think little things like, when you drive to the shops, could you park a couple of spaces further away because you get a couple of more steps to the shopping centre? Or if you meet your friend for a cup of tea or a cup of coffee, rather than sitting in the cafe and the weather's okay, could you go for that walk for 20 minutes and you've got your steps up and things like that? So little kind of hacks to get more exercise during your day. To kind of summarize the training side of things, these prescription guidelines are mostly focused towards kind of osteoporosis, but there will be beneficial effects for any sort of health in terms of cardiometabolic disease, cardiovascular risk, possibly even body fat or weight loss. So you've got your aerobic, which is more cardiovascular, like I said, walking, jogging, swimming, you know, housework, if that's all you can do. Nothing overly taxing. What to say, moderate pace. If you're able to talk to someone beside you, you're probably working at an okay pace. If you're extremely out of breath and you can't talk to the person beside you, it might be too intense. Scale it down. You know, 4 to 7 times per week. Start off with maybe, you know, 10 or 20 minutes. Doesn't necessarily have to be one big block. Gradually increase the distance you walk, or increase the speed at which you walk that distance. Try and build up strength. Start where you are. If you've never been in a gym before, do you go with home weights? Do you go with body weight? Do you go with resistance bands? And just try and, over the time, start to do a little bit more reps, work for a little bit longer, things like that. And then just general range of motion and flexibility. So even things like yoga or Pilates would be good, because you're still putting your muscles and your joints through ranges of motion, which will help with kind of muscle tone and things like that. So to kind of overall summarize, with good genes, good habits, good environment, good look, the effects of aging can be minimized. Nutritional and physical health can be maintained throughout adulthood.
Thanks, Richard. I just see there's a Q&A there.
Can I just give 2 more points? Sorry, just before I take some questions, I just want to highlight 2 things. The first thing is, I came across this. So UCD are running a menopause conference on the 13th of March. If anyone that's in here is interested in attending that, as far as I know, the event is on Eventbrite. So if people want to search that, it just might be of use. And also, I haven't talked about it here, but included in the slides at the end here are the kind of INDI Institute guidelines for menopause. But I just felt it would be a bit kind of intense to try and talk through them, but people will get those as well. Then I'll take questions. Sorry.
We've just one in so far. So it's Jacqueline wants to know, is this protein recommended based on average person, or would you be different for someone training, for example, a marathon?
No, well, for endurance athletes in general, the recommendations are somewhere in the region of 1.2 to 1.4 grams of protein per kilogram body mass. So if someone training for a marathon would likely hit those targets anyway.
And from Chris, is there any research on the effects, positive or negative, being vegan, vegetarian during menopause?
Great question. I didn't come across it. I didn't specifically look for it. My general understanding with vegans is they potentially are at risk of lower protein intakes because they're not consuming animal-based foods, and then I think potentially lower risk of low vitamin B intake. So I think what I do with my vegan athletes is I'd recommend slightly higher protein intakes, and I'd use what are called complementary proteins, where some of the plant-based proteins might be missing one amino acid, where you try and pair that with a plant-based protein that has that amino acid, and vice versa. So if Chris wants to look up like complementary or protein pairing, if they're a vegan, that might be of benefit to them.
There's two more in here. So we have, when should people start taking DEXA? Approximately what age?
I can't give a concrete answer on when. Like it kind of can be potentially a luxury thing for people, but the one thing I would say is like a single DEXA is just a single data point, won't tell you everything. I would probably be leaning towards, as you get towards age kind of 35, 40, maybe your first one, then you might not need another one for 5 or 6 years. I wouldn't necessarily say you'd need something every month or two. But as we're getting towards the kind of the peak bone mass for females is around kind of 30. So if you think, okay, well, it's going to drop off around 40 or kind of 45, if you can get one just before that point, that might show you if it's dropped off already. I would say if you got it like, without sounding kind of grim about it, it's not too late, but it could be past the point of meaningful intervention if you got it, say, at 70, for example.
Thanks. And Anne here, should you take calcium supplement just to be on the safe side? Like, are these menopause supplements worth taking, or is diet enough?
If you're concerned about your calcium intake, I'd recommend going to that Osteoporosis Foundation calcium calculator and see if you're hitting that 1 gram of calcium per day. From my understanding, once you're meeting your kind of minimum targets with minerals, going over and above them doesn't necessarily seem to have beneficial effects. So if this individual looks at their calcium intake and it's, say, 500 milligrams, half a gram per day, that's below the recommended intake. If they're able to bump that up, they'll likely see the beneficial effects. But then bumping that up again might not see any further impact. So I'm a big believer in food first where possible. So for something like calcium, which is readily available in foods, yes, you could probably get your calcium intake through foods. The caveat with that is, like, vitamin D, like I mentioned, isn't overly available in a whole pile of food. So that's where I probably would recommend a vitamin D supplement, yeah.
And we have Juliana. I have women friends going through menopause and have training and recycling regularly, but still gaining abdominal fat. How else would they counter or reduce fat gain?
What was the last? I broke up there, sorry.
How else would they counter or reduce the fat gain?
So they're already currently physically active.
Yeah, they're cycling regularly and they're still gaining abdominal fat.
If there's a way in which they could get some quantification or account on their calorie intake, would be where I would start, and seeing how consistent that is across the days of the week, and then seeing, is it appropriate for their body mass, is it appropriate for their activity level and things like that, and then look at their physical activity levels outside of their cycling as well.
Great. Yvonne, in excellent presentation, work in the area of women's health and will bring back many tips. Do you recommend magnesium and zinc supplements for someone doing a lot of cardio and strength training?
I don't. Again, I think if you set your diet up correctly and you're able to get your magnesium intake through your food and your zinc intake through your food, supplementing on top of that doesn't appear at the moment to offer any additional benefits. Usually where you see the benefits are people that have an insufficient level going up to a sufficient level, they start to reap the rewards. I'm not a massive fan of giving supplement companies money.
And we have Ellen is wondering, what's your opinion on protein yogurts, etc.?
Love them. So to me, that's just one of those fortified foods. Like if it's fortified with vitamin D or vitamin B or calcium, they've just tried to fortify these foods with protein. I prefer kind of more the dairy options because a lot of the proteins are whey proteins that come from dairy anyway. I'd be less likely to recommend protein bars, which are basically glorified chocolate bars. But again, if you want one every now and again, balance.
And probably take this as the last question and then finish up. Jackie, I'm 58, had a DEXA scan late 2022. I have osteoporosis in my lower spine and osteopenia in my two hips. Had a fall and dislocated my elbow in 2021. I'm very active, walking, running, cycling, do some form of exercise every day. I'm not sure what the question is on that one, Jackie. Oh, sorry, here. When should I get a DEXA scan and also have high cholesterol?
So the DEXA was 2021.
Late 2022. That should have fallen in 2021.
Oh, okay. Depends on how late in 2022, because we're 2 months into 2023. So if there's not that long of a time, bone turnover is ridiculously slow, I think. Like you'd need at least 6 months between scans to see any true meaningful change, which can be disheartening. But what I'd say to you there is keep the head down, stay active, stay doing what you're doing because you're doing the right things. I'd just double check on the side of your nutritional intake and see, are you hitting your calcium goals? Have you a vitamin D supplement? And what's your protein intake looking like?
Just a last comment from Anne. Brilliant presentation, and thank you so much.
Thank you.
Great, thanks for that, Richard, and thanks everyone else who's joined us. We'll email out a link to the presentation on YouTube, and we'll send on all the slides that Richard's going to send over as well. Okay, thanks for joining us.
Thanks, folks. Have a good evening.
Thanks, Richard. Bye-bye.
Thank you.